It's so nice to see the hall full. So, as ma'am has already mentioned that I am a radiation oncologist. I work at Tata Memorial Hospital. So I'll talk about the advances in radiation therapy in lung cancer. I have not kept my talk as an evidence-based medicine, but as a radiotherapy workflow. So because many of you may not be familiar with the radiation therapy, what is radiation therapy, and what do we do as a part of radiation therapy in lung cancer in specific. So I'll not go into the details about the lung cancer staging. We generally divide the lung cancer into the early stage lung cancer, the locally advanced lung cancer, and the metastatic non-small cell lung cancer. In locally advanced lung cancer, the radiation therapy plays a major part of the role, as well as in metastatic lung cancer. But in early stage, we also play a role that we'll see. If you see the stage-wise management, those stage 1 non-small cell lung cancer are generally treated with surgery or with the stereotactic radiation therapy. I'll come into the details about SBRT. In stage 2 and stage 3 is the surgery plus the chemotherapy, or if they are locally advanced or unresectable, then the concurrent chemoradiation therapy. And finally, the stage 4. Stage 4 metastatic non-small cell lung cancer are generally treated with a palliative intent, especially with the chemotherapy, targeted therapy, and immunotherapy, and sometimes for symptomatic treatment or for local consolidation with radiation therapy also. Now, what is the mechanism of action of the radiation therapy? The radiation therapy generally, whenever the radiation therapy is delivered to a patient body or to a tissue, so it enters the cell and they break down the DNA. As you can see, there are two mechanisms. One is the direct effect of the radiation therapy on the DNA, and the other is the cellular level. That means it interacts with the oxygen and inactive. There are the free radical molecule and which can damage the DNA. So there are both effects, the direct effect as well as the indirect effect. So this is the backbone of the mechanism of action of the radiation therapy, that it can damage the DNA. And if the DNA is damaged, obviously it will lead to the cellular death. That will be the tumoricidal death. Now, what are the advances in radiation oncology? The radiation therapy is there since 1910, when Madame Curie has discovered the X-ray and the radiation and the radioactivity. So from 1950 to 1990, there are major advantages in terms of the two-dimensional radiation therapy, but they were only limited to two-dimensional, mainly so based on the X-ray or the clinical marking. Means we will be treating only with the help of the X-ray. Now, in 1990 to 2000, there comes the role of the CT scan, and with the help of the CT scan in the radiation planning, we can do the three-dimensional conformal radiation therapy. I'll come into the details about all those things. And then 2000 to 2010, that's the intensity modulated radiation therapy. And then 2005 to 2015, we have the stereotactic body radiation therapy. And now we have the proton therapy also in our armamentarium. So what are the steps in radiation treatment? First of all, we need to do the simulation. Simulation means the planning procedure. How are we going to set up the patient? How are we going to treat the patient? So what sort of imaging modality we should have? And then comes the radiation planning. So this is the radiation planning. This is basically the work of the medical physicist as well as the radiation oncologist. And then the treatment delivery. So what sort of machine do we have for the treatment delivery of the radiation therapy? Just like the linear accelerator or CyberKnife or tomotherapy or Halcyon, there are various brand names available for the radiotherapy machine. And then comes the verification, because radiation therapy is not a one-day treatment. It will go on for approximately 5 to 6 weeks. So you need to make sure that the patient lie down in the same position, and we need to verify on a daily basis that the patient is lying down in the same position and the target is at the same place where you have already simulated 2 or 3 weeks as before. Now, so whenever we talk about the radiation oncology, I'm not the only one who will be treating the patient. I might be the face of the radiation oncology or the treatment team, but we have the radiation oncologist, the medical physicist, which will do the radiation planning as far as the plan is concerned, and then the treatment therapist, that the radiation technologist, which will deliver the machine, so which will deliver the radiation therapy on a daily basis on the machine. So this is a teamwork. Now, in the simulation, the patient should be in the treatment position. If I'm asking the patient to lie down on a supine position or in a prone position, the patient will lie down in a supine position for almost 5 to 6 weeks. We have the CT-based planning, so we need to do a CT scan for the radiation therapy planning. But generally, we take a slice thickness of 1 to 3 mm. It should not be more than 3 mm, because for the radiation planning, it is advisable or preferable to take the smaller cuts. And we can normally deliver the CT scan with an IV contrast. So IV contrast is helpful for the radiation therapy planning. It should cover the adequate area. For example, if I'm covering the lung, so it should cover adequately the thoracic region And for non-coplanar beam, I'll tell you later about the non-coplanar beams. Now the patient positioning is very important, because if you make a mistake here, then the mistake will be systematic error. The same mistake will be repeated on a daily basis and you may miss the target. So accurate reproducibility of the patient position is very important. It should have a minimum patient movement. The patient should not move during the treatment, because if the patient moves, we will miss the target. It should be comfortable, because it is going to be on a daily basis. It should be compatible with the image-based verification technique. So it should not have any metal within the treatment position or in the patient mobilization devices. It should not interfere with the treatment beam. Our treatment beam should be having a very free course of action whenever we are treating the patient. So these are the various sort of imaging available that we use in the radiation therapy planning. First one is the PET-CT scan, because PET-CT scan will help us in the target delineation for the radiation planning. The other one is also the PET-CT scan. As you can see, the CT scan will show only the size in terms of the, for example, 1 centimeter or 2 centimeter in size, but because of the prevalence of the tuberculosis, we may not be aware whether it is TB-induced lymph node or a malignancy-induced lymph node. So PET-CT scan helps there. There we have the MRI and the CT scan. Now, especially in the lung cancer, we treat the lung. So whenever you are treating a lung, the patient will inspire or expire. So the treatment or the tumor is continuously moving. As you can see on the free breathing on the left-hand side of the panel, the red one is the free breathing scan. So whenever you are taking a patient on a free breathing, it will just give you an approximate motion or approximate position of the tumor. But if you ask the patient, or if the patient take a deep inspiration, the tumor will move down. So because of the respiration. And during expiration, the tumor will move up. So we need to encompass the entire tumor motion while we are delivering the lung cancer radiation therapy. Now, as you can see, there is a small dot in the center of the red square. So that is the tumor. If the tumor is smaller and in the lower lobe, means near to the diaphragm, it will move to a larger extent in the radiation therapy planning. As you can see here, oh, that's the video. Yeah, so as you can see here, the tumor can move to a extent of approximately 2 to 3 centimeter. So if you position your beam, so without taking into account the tumor motion, we might miss the target, because if you position the beam exactly in the center, then in 1 minute the patient will be taking approximately 14 to second respiration. Then you will be missing the target approximately 14 times. So you need to account for that tumor motion. And how do we do that? We encompass the entire tumor motion with the help of 4-dimensional CT scan. Generally, we have a CT scan which is only 3-dimensional, but here the 4-dimensional CT scan also takes into account the time motion. Now, as you can see, this is the entire range of the tumor motion. So this needs to be accounted for the radiation planning, and then you need to deliver the radiation therapy. Now, what are the motion management strategies available to us? One is the motion encompassing, where we will take the 4-dimensional CT scan. So this is the 4-dimensional CT scan, or we can ask the patient to breath hold. But so many of the lung cancer patients are already existing smokers, so they may not be able to hold the breath. So we need to choose our patient carefully. Force shallow breathing with the abdominal compression. You can apply a instrument which can compress the abdomen, and the patient breathing can be reduced. Or we can have the respiratory gating. We have the machines available which can deliver the treatment beam only in a particular phase of respiration, only in particular respiration cycle. Or you can manually track the respiration, and then you can deliver the target. As the target is moving in the different direction, the machine can also move in the different direction. Now we have the 2-dimensional RT, which is less conformal, which was prevalent before 1990s. Now we have the 3-dimensional conformal radiation therapy. We have the IMRT or VMAT radiation therapy, or we have the proton therapy, which does not have any exit dose. As you can see in the 3D CRT, I'll explain to you in the next slide. So this is the 3D CRT versus the IMRT. If you can see the arrow, so one in the anterior direction and in the posterior direction, that the 3-dimensional conformal radiation therapy will deliver more doses to the normal areas also. But IMRT will deliver lesser doses to the lung, and this will help us to reduce the toxicity. So because the lung is a very radio-sensitive organ, if you deliver a larger dose to a normal area, the patient will come back with a sort of toxicity. We call it as a radiation-induced pneumonitis. The symptoms may be cough, the breathlessness, the patient will require oxygen, and the radiation oncologist life will be mess. and the lung SBRT. So whenever the stage 1 non-small cell lung cancer, we treat the patient with with a higher dose per fraction in a lesser number of fraction. So, as you can see in this particular diagram, it has got a smaller tumor size, but the target is very small and the target is continuously moving. And so the lung is also moving and the airway is also moving. So we need to have the lung tissue interface, because lung is a very low density organ, as well as the chest wall is a high density organ. So the beam has to pass through a high density organ to a lesser density organ, moving target, moving organ at risk, and the moving MLC. MLCs are the radiotherapy treatment machine equipment. Now the indications are the T1 or T2 non-small cell lung cancer, which are less than 5 centimeter, or maybe oligometastasis or the oligoprogression. The oligometastasis or oligoprogression are generally when the disease has spread to less than or equal to 3 sites in the body apart from the thoracic. Now the radiation therapy in locally advanced, whenever I call it as a locally advanced non-small cell lung cancer, it is generally unresectable non-small cell lung cancer. The management is the concurrent chemoradiation therapy followed by immunotherapy for 1 year. Stage 3 and stage 3C are the indication for the radiation therapy. The total dose is approximately 60 gray in 30 fraction. We deliver 1 fraction once a day for 5 fractions in a week, so approximately 6 weeks of treatment. The treatment modality is IMRT or VMAT. The chemo platinum doublet is the chemotherapy regimen that we use. The 5-year overall survival is close to more than 40%. As you can see, the number is not very great, but the lung cancer has a very dismal overall survival. But due to the advent of the targeted therapy and immunotherapy in stage 1 to stage 3 non-small cell lung cancer also, the 5-year overall survival is keep increasing. And the toxicity are the pneumonitis and the esophagitis. The pneumonitis is the dreaded complication of the radiation therapy in lung cancer radiation planning. If the patient develops any radiation therapy toxicity, then it is going to be very difficult for the patient as well as for us also. Now, these are some of the plans of the radiation therapy volume in locally advanced non-small cell lung cancer. As you can see, the patient can have a neck node as well as the mediastinal lymph node and the lung cancer. So the volume are generally larger. So we need to develop a technique where we can deliver the radiation therapy safely. We should not deliver a larger amount of radiation doses to the normal lung. So these are the sort of technique or the volume that we are going to treat. So we need to be careful whenever we ask the patient or counsel the patient as far as the radiation therapy, that they need to do their incentive spirometry to develop or to maintain their respiratory function or the chest optimization. For that, we need the help of the pulmonologist as well as the chest physician as well as the chest physiotherapy team. Now, so whenever we do the radiation therapy, as you know, the airway, there can be tumor which can block the airway. So if the patient is having a collapse or consolidation, that means the aerated part of the lung is not so great. So you can have the mediastinal shift. So whenever you give the chemotherapy and radiation therapy, the tumor will shrink and there might be an airway opening which can lead to the aeration of the lung. So if you see, this is the pre-radiotherapy planning CT scan, and then we started delivering the radiation therapy. So if you do not verify the treatment on a daily basis, then what will happen? The patient can have either the progression, the chances are less, but the patient can respond to the treatment. If the patient responds to the treatment, then the tumor will shrink and the mediastinum will go into the normal position. Now, if we deliver, as you can see the red color box, there is a normal lung over there. So if you do not account for the improvement in the or for example, the change in the tumor position or change in the normal anatomy, then you will deliver the radiation to the normal areas. So you need to adapt based upon the radiation therapy response as well as the chemotherapy response. So we need to take the CT scan again, we need to do the every step again, and then you have to adapt the radiation planning. Otherwise, you will deliver the area where the disease is not there, but the normal lung is there. So you will miss the target, you will not have the response, else you will have the toxicities of the lung. So these are the treatment verification that we do on a daily basis on the radiotherapy machine. So with the help of the CBCT or the cone beam CT scan or the MRI, it is very important to verify the treatments before you deliver every fraction, especially in lung, the brain or in the spine. Now, coming to the palliative setting, the palliative radiation therapy can be delivered to the primary disease whenever the patient is symptomatic for excessive cough or breathlessness, or there is an airway obstruction. To relieve the airway obstruction, bone metastasis, brain metastasis, the adrenal metastasis, or the oligometastasis. Approximately more than 80% of lung cancer patient diagnosed in India comes in stage 4. So we have only 20% in stage 1 to stage 3, and majority of them comes in advanced stages like the metastatic in approximately 75 to 80% of the patient. So these are the radiotherapy for bone metastasis. So many a times you must have seen that the patient is coming so with a bone pain, and it is an excruciating bone pain, so which is not responding to the analgesic. And the radiation therapy can relieve the pain in approximately 70 to 80% of the patient within a week or 2 weeks of time. So you need to deliver the radiation therapy for the bone metastasis. As you can see, there are 2-dimensional technique, the 3-dimensional technique. Now with the help of the stereotactic radiation surgery, or so with SBRT, we can deliver higher doses to have a better local control as well as the pain response. Now, coming to the SBRT spine, so many of these times we need to deliver very high doses, for example, 12 into 2 or 24 gauge single fraction to the bone to have the maximum local control as far as the bone metastasis is concerned. Why we do the SBRT spine? Because of the advances in the targeted therapy and the immunotherapy, because the patient is living longer. So if you deliver only lesser doses to that particular bony metastasis, they will come back to you again with the help of for example, pain, or we have the local progression over there. So we need to deliver higher doses, but we need to select our patient population very carefully that they should not have overtly metastatic disease. And these are the radiation therapy for brain metastasis. Brain metastasis is a common complication of lung cancer. The patient will have headache and all sort of symptoms. The patient will have the edema. We need to have the 2-dimensional radiation therapy. We are still practicing 2-dimensional radiation therapy because of the volume that we get on into the Tata Memorial Hospital. Approximately, we treat on a daily basis approximately 2 or 3 patients for brain metastasis from lung cancer. We have the 3-dimensional technique. We need to select the patient. We also can deliver SRS or the hippocampal avoidance WBRT. So what happens is that whenever we deliver radiation therapy to the brain, there might be some neurocognitive decline. So in the memory function or in the learning, especially they are young, especially female, they are young. So because majority of the non-smoker lung cancer will develop in the female population, and they will have the brain metastasis. So we need to preserve the area of the neurocognition, so which is called as the hippocampus. So we need to spare the hippocampus, as you can see here in the below photograph, that we have spared a strip of the normal brain parenchyma, which is the location of the hippocampus. And we can also deliver the SBRT or SRS for the brain metastasis if they have solitary or 1 or 2 lesion. So the indication are whenever they are having less than or equal to 3 brain metastasis, the dose will be delivered approximately 20 to 24. So mind you, these doses are very high. 20 to 24 single fraction in a small volume. If you deliver 8 gauge single fraction to, or maybe 4 gauge single fraction to entire body, the patient can have a very dreaded complication. So these doses are very, very high. You will not get a 1,000 or 10,000 of the dose in the normal population also. So these doses are very high. You need to carefully select the patient population, and you need to deliver very precisely. So with this, I would like to thank you all, and I can help you with all the questions that you have.
Any questions?
Whatever radiation therapy you told, are there any limitation of activity in the patient due to this radiation therapy after this?
Limitations, yes, there are limitations. For example, if you are delivering a patient with, for example, stage 3 non-small cell lung cancer, the patient should not eat or drink spicy food. So because of the esophagitis, so because of the inflammation in the food pipe or in the esophagus, so there will be inflammation of the esophagus. So the patient can have the pain in the chest, in the midline chest, and the patient will not be able to swallow the solid food. So the patient will have to swallow a semi-liquid diet or a semi-solid diet. So we need to counsel that the patient might have the grade 2 or grade 3 esophagitis. So they should not eat oily, spicy food and very raw food.
A very nicely taken lecture.
Thank you.
From basics you have started, and we could understand each and everything, I suppose. Very nicely taken, and thank you so much. I think as there is no more doubt, okay, one more doubt is there, 1 second.
Sir, there are some patients who are coming to chemotherapy and at the same time they are for CTRT, means concurrent chemotherapy and radiation therapy. But because of some of the patients which we cannot give the chemotherapy on the same date of radiation therapy, so what could be alternative for that, or is the patient required to be taken chemotherapy on the same day of radiation therapy?
Yes, ideally the chemotherapy and radiation therapy should go hand in hand. We should not miss the radiation therapy or we should not miss the chemotherapy, because if you miss the radiotherapy, they can have a decrease in the local tumor control. So ideally, yes, if the patient is on chemotherapy, either before, ideally after the chemotherapy, the radiation therapy should be delivered, or it should be delivered on the same day.
Okay, because some of our patient comes for cisplatin chemotherapy at night, and on the same day, in the same time, the patient has to take radiation in the morning or some particular decided time. But patient could not come, or because of some other reasons, so they could not take the radiation on that day. So
we need to counsel them that they need to
they
take
should be
that.
taken.
Yes.
Okay. Yeah. Thank you.
Thank you.